So good afternoon again. I'm going to talk about managing cataract with corneal scars. So we do come across these type of corneal scars with the cataract, and how to deal is a big problem because there is impending visualization, there is problem of biometry, intraoperative difficulties, and there are many options available, like you can go for the cataract surgery alone or simultaneous keratoplasty and cataract surgery, or you can go for the cataract surgery after keratoplasty. And these options are available on various factors like location and density of the opacity, whether the patient is status of the patient, monocular or binocular status, then surgeon expertise, availability of the donor cornea, and patient expectation. All these factors depends how to choose the option. When opacity is peripheral or paracentral and one half of the cornea is clear, that time we can go for the cataract surgery alone, which gives faster visual rehabilitation, but there is always difficulty in the surgery. When we go for the simultaneous keratoplasty and cataract surgery, there is shorter visual rehabilitation period, but there is greater risk of the complication and risk for the graft failure. If we go for the cataract surgery after keratoplasty, there is achievement of the refractive accuracy, but always risk of endothelial loss and graft rejection. When we do the cataract surgery alone, certain modifications are required. We will just talk about one by one. Site of incision should be one which provides the maximum clear working field. Means if the opacity is in the inferior part, you can make the incision at the 12 o'clock position so that you get a clear area. You should use the maximum, you should take the maximum use of OVDs, as they not only provide the lubrication when they are placed over the corneal surface, but they also increases the magnification and they provides better visualization, and you can use repeatedly several times during the surgery. Illumination is the another factor which can give you good visualization. You can change the position of the patient's eyeball to get a good illumination. You can change the position of the microscopic intensity of the light, or you can use the retroillumination or the by fiber optic light, as you are seeing here. You can see the clearly, and then you can go for the further steps by using this fiber optic light, or transconjunctival chandelier illumination can be used. Pupillary expanders are required in such cases because often there is atonic iris is there, there is pre-existing posterior synechias, poorly dilated pupil is there. So pupillary expanders, they not only expand the working area, but they can expand the pupil beyond the corneal opacity, so that the visibility is increased, and enhanced visibility provides good surgical steps with less complications. Capsular rhexis is another important step. So after staining, you should start the capsular rhexis in the visible area where you can see the clearly see the lens and capsule. Start with the whatever way you want to start. Use viscoelastics as and when required. This was case of hypermature cataract, so the liquid fluid was coming out, so drain out the fluid so that you can keep on identifying the capsular edge. Underneath the corneal opacity, you can use the forceps, hold the edge of the capsule, and then in a single motion in the centripetal direction, you can complete the rhexis. But if you leave the edge, again use the viscoelastics, and then you can rehold the rhexis. Nucleus emulsification is also not so easy. Always be in the clear area where you can see the nucleus, whether it is hard cataract or any type of nucleus grading. You can do it clearly if you are there in the clear area of the opacity. So in case of hard cataract, you can go for the eccentric crater and chopping. And if there is, as soon as you start eating up the nucleus fragments, the clarity increases and rest of the things can be easier. Intraocular lens implantation, in case of paracentral opacity, you can put the large size of lens so that it can cover the larger area. Simultaneous keratoplasty and cataract surgery, you require little expertise, and when there is full thickness corneal opacity, you and central corneal opacity, donor button is available, you can go for it. I always do the UBM before going for the penetrating keratoplasty in such cases, because that only I can predict that whether there is cataract is dense or not, whether status of the whether it is aphakic or not. So in the lower one, I could already knew that this is aphakic patient, so I make the for the scleral fixated, I was prepared for the scleral fixated IOLs. So after removing that cortical matter and doing the anterior vitrectomy, I just this inserted three-piece lens for the scleral fixated, and one haptic is out now, and then the another haptic was taken out and fixed in the groove. But it is not very easy in while doing the open sky while penetrating keratoplasty, as the globe is very very soft, so it is little difficult to handle it. And in another case video, you can see the open sky rexis was done, and then the lens was removed, and then PCIOL was inserted. Well, so this way you can manage whether you want to go for the cataract surgery alone or simultaneous keratoplasty. Cataract surgery after keratoplasty, Dr. Pratik Gujar is going to cover, so I'm not going to talk about this. So this is the way you can manage by certain modification for the better visualization. You can go for the cataract surgery in the corneal scars. Thank you.